Our next panel is going to address another really important topic which we have alluded to a little bit earlier in our meeting. Resource considerations and implementation barriers. And Tim Coetzee is going to moderate this session.
Well, thank you, Bernie. We have another diverse panel to really start to grapple with some of these issues of resources and implementation that we've touched on. So we'll hear from Atul, from Janet Witz, Matt Gross, and Kenneth Mock, who will give us the range of perspectives. Atul?
Great. So again, Atul Butte. I'm at Stanford, associate professor. And I run this repository. So I'm here because I run this NIAID-funded repository called Import, which I'll explain. Same disclosures as yesterday. So Import is this repository. It's been in business for about 5 to 6 years, and about 19 funded consortia funded by NIAID, Allergy and Infectious Disease from NIH, have to share their data with us. And here to specifically talk about the resources used, what's the FTE count from the submission side, the data reuse side, and infrastructure and challenges. So just actual track record, and I spent the day actually getting some of these numbers because I could see where we were going with this. So the consortia have to submit their data. They're tasked with doing this. It's now being written into their RFAs, and I'll show you an RFA issued yesterday that actually proves this. And or from contract research organizations. We love working with the consortia. We really love working with the CROs because it's already organized and they understand how to submit the data, and they themselves are contracted by NIAID to submit us data. If I add up the numbers, I know what my direct costs are. The denominator is the hard part here. What am I dividing by? Because this 15% keeps floating around. So if I just add up all of NIAID, Division of Allergy, Infectious Disease, and Transport, so date, NIAID date, so not bioterrorism and all the rest. If I just count extramural contracts and consortia budget, I get a couple, millions of dollars, and I look at mine. Ours about 1% of that number. Obviously, if you change the denominator, this percent changes, but that's perhaps the reasonable denominator because we're expecting all of them to give us their data, and we're expected to represent that data. So we have this consortia, this infrastructure already in place, but the ongoing costs are about a 1% of their budget, of the date, but extramural budget like this. Every lab, consortia, group has to expend their own effort to de-identify and upload to us their data. We give them templates to do this. We give them ontologies to use. Ontologies are in Excel templates, and we make them better every once in a while. And we respond to newer types of modalities of data, especially the molecular data. And when we look around, when we survey, it's about a partial FTE for some, like the CROs that are doing a lot of this work already anyway, partial FTE to get ready and de-identified, 2 to 3 FTEs, depending on those consortia have a wide variety of data. They're not sure where the identifications might be. It takes a little bit more effort there. On our side, on Import, we have 3.5 FTE dedicated to curate and represent the data. That means taking the data and in many cases representing in a data model that we've published. So you can download the tables and actually figure out how to reuse them. And that gets about a throughput of about 70 studies a year, just so you have real numbers here. The contract research organization's role is critical. It might be great to get more input from the CROs for your panel, but they do a lot of this work. They understand what their job is, and they're really working hand in hand with us and getting this data out there. The timeline, if you look at the latency, it takes anywhere from 2 weeks to several months. I'm just putting factors what slows this down for us in our infrastructure. Size of study, obviously. Number of participants increases the time. The complexity of the study design, multiple arms, arm switching after arms. Increased molecular data slows us down, so we have something to gigabytes to hundreds of gigabytes. And partial releases, and that really slows us down. Here's all this data, but we've only published on X, and we only want you to release X. So we have to go through and figure out where X, the line for X is. Complying with an external standard will definitely take more effort. Right now, we release these in tab-delimited files. You'll see that in a second. Complying with a future standard like CDISC or Bridge will slow us down, but we also understand that could be necessary for the downstream applications. Here's just one example of an NIAID released RFA, released yesterday. This is a renewal of a program called Human Immunology Project Consortium. It's one of their flagship projects, and I just highlight everywhere Import shows. I just want to read the sentence. At the bottom, it says that funding beyond the first year may be negotiated downward depending on the progress in meeting the data and other resource sharing milestones. So this is great from my perspective. We could see more of these, but NIH can do this if they want to. They can say you will not get more money beyond year 1. Forget about the renewal in 5 years, beyond year 1 if you don't comply. On the data utilization side, we have already released about 100 trials or studies, hundreds of downloads of these per month, about 20 or 30 actual investigators, mostly academic. Our own academic team, so why am I in this as a professor? Because I can write papers on this same data too, and I can take data set here and data set here, mash them up, figure out something nice. I can write papers. So I have the usual academic credits too. Yes, there's grant dollars involved, but I feel like I can write papers because it's open to everyone. I can write some too. We also are part of the effort to fix the data upstream before a lot of other people download it. So curation errors and data representation errors, the biggest kind of bugaboo for us are temporal issues. That's visit 1, encounter 3, study date this. Lining all those up tends to be hard. On the reuse side, data reuse is still non-trivial. So it's functionally limited to experts. So it's not necessarily the high school kids that we keep talking about downloading this data. We want them to be able to. We are going to be teaching them how to do this, but still limited to the experts who know how to make use of this data. And because of that, because they're essentially self-selected experts, we have nearly 0 calls or emails to our help desk asking for help in using this data. So our help model, we have a help desk email. But our model is more like NCBI. I don't think people call NCBI when they have trouble downloading a sequence from GenBank. DHHS gives out Medicare, Medicaid data. I'm not sure if they even have a phone number to call. Data.gov has 500,000 people downloading data, right? This isn't the first data release from the government. There's many examples. 500,000, I don't think they have a help desk either. So it's kind of that model there. You could just see, you could just click to download tab delimiter MySQL, just put a couple rows there. And the last point about qualified researchers. Currently, we approve anyone with an email address, okay? It could be a Gmail, okay? It can be anything. They have to have an email address, and they got to agree to an online use agreement. Now, the use agreement was written 6 years ago. It will be morphing as we go. And when you click on the links, you get a long access agreement that actually really governs the submitters of the data. You shouldn't submit data here unless you have rights to submit that data. It does not specify or restrict your terms for reuse at all. An open issue for us is whether we can actually even get rid of this and whether we can actually release more data without an account. And where we're starting with that is all the primate studies. Turns out people try vaccines in primates. There are no humans involved. We will try to release that as putting our toe in the water. It is still functionally difficult to reuse the data. So patients, we've been talking about patients a little bit. We don't think patients might directly get data from the site, but they might work through their support groups. They might work through their disease organizations. And we can also imagine companies coming in and resharing our data. And actually, we would not be opposed to that necessarily, speaking for myself. I'm just giving one example, and this is just a model. This is a use case. NextBio is a company started in the South Bay near Sunnyvale. And they got $16 million in external investment, so venture capitals, and they took the data, the molecular data in NCBI Geo, and they recurated it and actually provided it up to almost 100 other customers. I'm not involved with this company. They were getting $5 to $10 million in revenue. They created 75 jobs doing this, and then they just got acquired by Illumina late last year. So that would be a success story from one perspective, that they've created jobs, they've shown that people want this data, and actually there's a better way to get to it, and external investment is actually driving that infrastructure, not necessarily even taxpayer dollars here. So that would kind of be a win for us. Finally, our servers live in the NIAID data center at NIH. We're moving towards deploying our service in the Amazon space just to improve the firewalls, things like that. We do provide these upload templates working on relevant ontologies. We're not at level of perfection yet. We really see better software tools coming out to organize, upload, download the data, reanalyze it. We really still need that. We anticipate third parties developing them. We're opening up what are called APIs, application programming interfaces, to better get those developed. I'm just ending with the quote that perfection here is the enemy of the good. So I'll sit down.